offices in the regions, but also in countries. Hopefully that gives you some information about what WHO is doing around the world. Today, Dr. Tedros, Dr. Maria Van Kerkhove, and Dr. Mike Ryan are here with us to answer your questions, but I will give the floor first to Dr. Tedros.
Hello, everyone. Globally, almost 2.5 million cases of COVID-19 have now been reported to WHO, and more than 160,000 deaths. We see different trends in different regions, and even within regions. Most of the epidemics in Western Europe appear to be stable or declining. Although numbers are low, we see worrying upward trends in Africa, Central and South America, and Eastern Europe. Most countries are still in the early stages of their epidemics, and some that were affected early in the pandemic are now starting to see a resurgence in cases. Make no mistake, we have a long way to go. This virus will be with us for a long time. There is no question that stay-at-home orders and other physical distancing measures have successfully suppressed transmission in many countries. But this virus remains extremely dangerous. Early evidence suggests most of the world's population remains susceptible. That means epidemics can easily reignite. One of the greatest dangers we face now is complacency. People in countries with stay-at-home orders are understandably frustrated with being confined to their homes for weeks on end. People understandably want to get on with their lives because their lives and livelihoods are at stake. That's what WHO wants to. And that's what we're working for all day, every day. But the world will not and cannot go back to the way things were. There must be a new normal, a world that's healthier, safer, and better prepared. The same public health measures we have been advocating since the beginning of the pandemic must remain the backbone of the response in all countries. Find every case, isolate every case, test every case, care for every case, trace and quarantine every contact, and educate, engage, and empower your people. This cannot be effective. The fight cannot be effective without empowering our people and without full participation of our people. Countries that do not do these 6 central things and do them consistently will see more cases and more lives will be lost. To be clear, WHO's advice is to find and test every suspected case, not every person in a population. WHO is committed to supporting all countries to save lives. And we're also committed to human rights and to fighting stigma and discrimination wherever we see it. There are disturbing reports in many countries in all regions about discrimination related to COVID-19. Stigma and discrimination are never acceptable anywhere at any time and must be fought in all countries. As I have said in many times, this is a time for solidarity, not stigma. WHO is also working actively to address the impacts of the pandemic on mental health. Working with mental health experts around the world, WHO has produced technical guidance for individuals and health workers, recognizing the enormous strain they're under. In addition, we have also developed a free children's book about COVID-19 with partners from UNICEF, UNHCR, IFRC, and UNESCO, among others. In less than 2 weeks, we received requests to translate the book into more than 100 languages. And the book is now being used among Rohingya children in Cox's Bazar and children in Syria, Yemen, Iraq, Greece, and Nigeria. One of WHO's core functions is to provide evidence-based technical advice to countries. This is not something we do alone. Every day, we work with thousands of experts all over the world to collect, analyze, and synthesize the best science and turn it into guidance that we give back to countries. Through thousands of hours of discussion, we have exchanged first-hand experience and debated the science to generate the advice that we make available to all countries. We then work with countries to turn that guidance into action. WHO has staff in 150 countries all over the world, working directly with government, scientists, and partners to coordinate national preparedness and response plans and to implement them. I would like to use this opportunity to thank all my colleagues all over the world in all our 150 offices for their hard work and commitment. In addition, WHO has sent more than 70 surge teams to countries to strengthen surveillance and provide advice on infection prevention, how to treat patients, risk communication, lab capacity, data management, and much, much more. We have also brought in external support through our Global Outbreak Alert and Response Network and Specialist Emergency Medical Teams, what we call GORN, or Emergency Medical Teams, EMTs. And I would like to thank GORN. In addition to supporting countries, we also track progress global data. 70 have a preparedness and response plan in place. 76% have surveillance systems in place to detect cases, and 91% have lab testing capacity for COVID-19. But we still see many gaps around the world. Only 66% of countries have a clinical referral system in place to care for COVID-19 patients. Only 48% have a community engagement plan, and only 48% have an infection prevention and control program and standards for water, sanitation, and hygiene in health facilities. In other words, there are still many gaps in the world's defenses, and no single country has everything in place. WHO will continue working with countries and the international community to close these gaps and build sustainable capacities for now and the future. But we are not alone. We work with partners all over the world to harness their expertise and networks. Earlier this week, WHO and the International Telecommunication Union announced that we are partnering with telecommunications companies to reach people directly on their mobile phones with text messages about COVID-19. This will help reach half of the world's population that doesn't have internet access, starting in the Asia-Pacific region and then rolling out globally. We're calling on all telecommunications companies globally to join this initiative to help unleash the power of communication technology to save lives. We also issued a call with the World Trade Organization, calling on countries to ensure the normal cross-border flow of vital medical supplies and other goods and services, and to resolve unnecessary disruptions to global supply chains. We need to ensure these products reach those in need quickly, and we emphasize the importance of regulatory cooperation and international standards. Finally, with the holy month of Ramadan starting tomorrow, I would like to wish all Muslims around the world Ramadan Kareem. This is a season of reflection and community an opportunity for kindness and solidarity. Earlier today, I spoke to health ministers from across Eastern Mediterranean region. I assured them that we will stand in solidarity with them, as we will stand with all countries. We're all in this together, and we will only get through it together. Again, Ramadan Kareem. Shukran jazilan.
Thank you very much, Dr. Tedros, for these opening remarks. So we will start with questions. So I will remind journalists that they can, if they are joining us online, that they can select the language on the interpretation tab, and that obviously you can ask questions in any of 6 UN languages and many more to come. So maybe we will start now with Dakar, with Senegal. Réveil Dakar, and that's Tierno. Can you hear us, please? Sorry, I think there was a little issue. Let's go to maybe, do we have Jeremy on from? Let's go to Jeremy from RFI. Jeremy, can you hear us?
Yeah, can you hear me, Tarek?
Yes, please go ahead.
Thanks for taking my questions.
And so we have outlined a number of factors that need to be taken into consideration. First and foremost is to really understand where this virus is, how far it's being transmitted, and if it is controlled. And there are measures in which you can look to see if that's actually being achieved, how many of the cases are actually being detected. It's very important that once these an understanding of this virus is understood through the surveillance activities, countries need sufficient systems in place to be able to detect any new cases that come up. And so that's really important, so that if there is a resurgence, and we are seeing in a number of countries now that those that were successful in controlling, they are seeing a resurgence in cases again. And that's because a large proportion of the population does remain susceptible. And so there are a number of additional factors that we've outlined that need to be taken into consideration, but it doesn't mean that you won't see your families for long periods of time. There may be situations in which these measures can be lifted, but it will have to be done in a controlled way. It doesn't mean that you can't see your family members through social media and through other kinds of communication, but I realize that's absolutely not the same as being able to give them a hug. And so there isn't a one-size-fits-all. What we've tried to do is we've tried to outline the considerations that need to be taken into place for those who can make those decisions, and then given the context, the decisions will have to be made at that lower administrative level.
And if I could add, I think your question referred specifically to older persons living in society, and each society is structured in different ways. In many societies, older people live in generational families and are continuing to do so, and families are doing their best to protect them. What we've seen in the context of Europe and North America, though, are very intense series of individual outbreaks inside long-term care facilities, which have been quite devastating. And the risk of such events occurring into the future, as long as the virus is here, there's always an opportunity for that to happen. But at the same time, it is very difficult to reduce that risk to zero. So I think each country is going to have to look at how can we minimise the risk of bringing disease into such a setting. And there are lots of measures that can be done to minimise that risk. And even more importantly, how are we going to pick up a signal that something has gone wrong, that there may be a case in that situation, and how do we rapidly shut that down and deal with that very effectively? And that's going to be that. So both the risk reduction and the risk response, the response to an event if it occurs. I'm sure there are many, many, many older people living in long-term care facilities who, at the best of times, are lonely, and for the last number of weeks has been a terrible ordeal for them, both to be further isolated, but also with the constant threat of potentially becoming sick with this disease. As the disease dies down or comes under control at community level, then the risks obviously reduce for those long-term care facilities. But the consequence of disease getting into those facilities, I think, is clear and stark. So how do we protect and shield our oldest and wisest and most precious members of our society, while at the same time not entirely cutting them off from the very things that makes us human, and that's our ability to be part of a community. And these are trade-offs that are very difficult to manage. My own view is that the risks can be managed. They need to be recognised, then managed. And if in a situation where we do see disease occur in a long-term care facility, we must be ready to react very quickly to stamp out that disease. It's also important that carers in these facilities have adequate training, that there's an adequate design in facilities, there's adequate staffing in facilities, and that we look again at the support, design and environment that we offer for our older citizens, and that those environments are made not only more comfortable and more human, but also safer. And I believe that can be achieved, and I believe there are lots of ideas on how that can be done. So I think we need to maybe also look at the model of the way in which we're providing care and support for our older citizens. So there's a lot to be done, but I do think it's a major issue. I think if you look around Europe now and in North America and Canada, a large proportion of the intense disease transmission is actually concentrated in long-term care facilities, which is in itself a tragedy, and it's also a challenge.
Thank you very much. Next question is from our friend, Geneva-based reporter Moussa Assi. Moussa, can you hear us, please?
Oui, je vous entends bien. Bonjour tout le monde. Ma question concernant les pays qui continuent à rapatrier leurs citoyens, est-ce qu'il y a des programmes aussi pour continuer ces rapatriements jusqu'à des mois à venir? Est-ce que vous les encouragez à continuer ça, ou bien vous croyez qu'on est peut-être arrivé au point de terminer avec ces virus et par conséquent, il ne faut pas continuer? Merci beaucoup.
Thank you very much, Moussa. The question is about repatriation of nationals that is taking place.
I think there are a number of countries around the world who've been repatriating students and other citizens from different countries around the world. And again, we commend the efforts countries are making to protect their citizens, the first duty of government. But at the same time, we have to now look to the future. And when we talk about opening up and reducing lockdowns, there's also the question of how people begin to move internationally. A lot of the discussion up to now is how do we create the possibility of movement within countries. Obviously, the need to move between countries is going to become more and more an issue and more of a challenge. So I think the issue of moving citizens home or just getting people back into international travel is going to have to be approached carefully, and it's going to have to be done, I would suspect, first at sub-regional level. I think already countries with borders with each other are beginning to come to arrangements of how people can move between countries. I think we're seeing that already in the likes of the European Union. I think we're seeing that between ASEAN countries and others. And countries are looking at how we can re-establish links and movement between our countries. Some of that will be based on, I think, risk equalisation and response equalisation, where countries have a similar control of the disease and where countries have confidence in the measures being implemented in the other country, then in effect the risks are equalised and the movement of people between those areas, in a sense, doesn't add risk to the other country. Where there's a differential in transmission and where their disease is under control in one country and maybe out of control in another, then countries will have to look at how they manage travel from those countries, and that would include their own citizens. So I think a lot of the initial work that's going on is at sub-regional or regional level, and then opening up global travel, again, is going to require careful risk management, adjustments by everyone. We've said it, I think everyone is saying it, the new normal. I mean, society, until we have longer-term solutions for this and until we understand this virus better and its transmission and whether it will come back in a more damaging way even, we have to be very prudent. But I believe, again, these risks are manageable because if, as the Director General has said many times, countries have in place the 6 elements of detection, testing, isolation, quarantine, care, and educated communities, then I believe those ingredients can bring, and if every country is implementing a similar strategy, and if every country gets to a point where the disease is under control, then the risks between countries become more equalised, and the movement of people then can be easier. And I think there's a lot of discussion on that, and WHO will be very pleased to bring countries together. We're already convening countries at regional level to discuss these matters. I know the Director General spoke with ministers in the Eastern Mediterranean region today. There have been a whole series of different engagements from our regional directors and others over the last couple of weeks. So we will continue to work with countries to support them in trying to find ways to create and sustain movement both within and between countries in the coming weeks and months.
Thank you very much, Dr. Ryan. Next question comes from Christophe from Rwanda. Christophe, can you hear us? I think we lost Christophe. Then we will go to Savio Rodriguez from Goa Chronicle from India. Savio, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, please go ahead.
Okay, my question is to Dr. Tedros, and it's a very simple question. The question is, if he had an opportunity to rewind back the last couple of weeks where we've been going through the coronavirus pandemic and certain decisions that were taken by the World Health Organization, would he have called the coronavirus a pandemic earlier? Is my question. If he had the opportunity to rewind and go back, would who have called the pandemic earlier than it did much later?
Dr. Tedros may speak to this, but let me clarify to you technically. WHO raised its highest level of alert under international law on the 30th of January this year and declared a global public health emergency. That is under the International Health Regulations 2005, which is an international legal agreement between all of our member states, which asks that WHO declare such an emergency where the Director General has received advice from an emergency committee and makes that determination based on that advice and the situation. The characterization of the disease as a pandemic in itself has no basis other than a description of the event at that time as regards how many countries were affected. The global public health emergency was declared on the 30th of January, and that is the highest level of alert that WHO can declare.
If I may add, I think, there will be plenty of time to look backwards, and one of the things we've been trying to do is look at what countries are doing. We go into these deep dives on certain countries to evaluate how measures have been put in place, and we've seen some really good ones recently. You've heard us talk a lot about China, you've heard us talk a lot about Korea and Singapore and Germany, and we have now more and more countries in different regions that have highlighted what they're doing. For example, in Africa, we're seeing a number of countries who are still seeing imported cases. So they haven't reached a point in time where the disease has really taken off and they've reached that exponential growth where it's growing very, very rapidly. And in many countries, what they've done is they've implemented some of these public health measures and social measures they've put in place when they've had less than 100 cases in each country. And in doing so, they've been able to slow it down. They've been able to slow down that transmission. And importantly, once those measures are in place, which are difficult, have societal impacts, which have economic impacts, which have personal impacts, it's slowed down transmission of the virus, and that time has been used very, very wisely. What we're seeing is in a number of countries, they are doing everything that they can to ramp up testing. So building on existing systems that they have, whether it's national influenza centers that exist. And we're working very hard through our regional offices to ensure that countries have those tests in hand to be able to detect cases. We've seen a lot of efforts across the globe, and in the countries I'm talking about in particular, to sensitize the communities, to empower the communities, to say this is what we can expect, this is what we need to do. This is what you need to do as an individual and in your families, and this is what we need to do as a government. We've seen improved efforts to strengthen surveillance. So whether this is making sure that there is a workforce in place, so actual individuals who can go out and find cases, whether these are people who could do contact tracing, and whether it improves the workforce within healthcare facilities.
We have someone online that we can't identify, and who so I think it's okay now. Sorry for this.
That's okay. It sounds like some people have kids at home. So just to say that this time is being used wisely to build up that workforce, to identify where those cases are, to find the contact tracers, and also to ready the hospital systems. So not only building facilities or identifying locations where non-traditional places where mild patients may be treated, getting those beds ready, making sure those supplies are purchased, are acquired, training healthcare professionals in infection prevention and control and clinical care. I think what we're seeing is many countries are using this time to really build that infrastructure, that public health infrastructure and the hospital systems in place to get ready for when those cases do come. So I think that message has reached many, and that's been our message from the beginning, and we will keep saying that because this is what works. So even in countries that are now seeing a resurgence in cases, they're coming back to this again. How do we find every case? How do we test all of the suspect cases? How do we care for all of them appropriately? And how do we trace and quarantine all of the contacts and keep our community engaged?
Yeah, thank you. I would like to add to that. I think my colleagues have already said, based on the IHR 2005, what is expected from WHO is declaring the public health emergency of international concern as early as possible, based on the factors. And as Mike said, the highest emergency as far as international health regulation is concerned was declared on January 30th. And during that time, as Maria said, there were less than 100 cases. And to be specific, 82 confirmed cases on January 30.
Outside of China. Outside of China.
Outside China. Of course, in China we had more cases, but outside China we had only 82 cases. And most of these cases were actually in the neighborhood. And most of them, since they're in the neighborhood, the rest of the world is still reporting no cases. We had few in Europe, and I can read that for you, what was reported from Europe. We had 5 from France, 1 from Finland, 4 from Germany. That makes it 9. 10 actually. 10 cases in Europe when we declared global emergency. In Africa, we didn't have any case. In United Arab Emirates, from the Middle East, United Arab Emirates had 4 cases. So you can see it for yourself. We triggered the highest level of emergency when the rest of the world had only 82 cases and no deaths. And then to add to that, global emergency is discussed among experts. It's not just one director general who just comes out and declares. We have experts representing all over the whole world coming together as experts and discussing. And they met on 23rd January. They couldn't agree, they were divided. Then, of course, they continued for a second day. Still, they couldn't divide it. They couldn't agree. Of course, they agreed to meet in 6-7 days and then met for a second time on January 30 when they, based on the criteria we have, they were convinced that the criteria is met to declare this global emergency. So I want to be clear again. The most important thing which is expected as a declaration from WHO is the global emergency declaration on January 30. And that was declared based on experts' opinion that was drawn from all over the world, who used the criteria to recommend to me that this is already a global emergency, and that consensus led to a declaration of global emergency from WHO, which I announced myself. So looking back, I think we declared the emergency at the right time, and when the world had enough time to respond, when the rest of the world had enough time to respond. I repeat again, there were only 82 cases and no deaths. That was enough to cut it from the bud. Enough. That was January 30. And this is more than 2 months and 21 days ago, close to 3 months now. Thank you.
Thank you very much. We will try now to go to Democratic Republic of Congo. We have Sami there from Congo, Czech. Sami, can you hear us?
Oui, merci beaucoup. Merci beaucoup pour la parole. Je voulais savoir à quel regard l'OMS porte en général sur tous les médicaments en train d'être développés sur les continents africains pour lutter contre la COVID-19. C'est l'exemple de Covid organique qui est développé, qui a été validé au Madagascar. Il y a également la vipirine au Bénin et même en RDC chez moi, où plusieurs autres médicaments sont proposés, bien que non encore validés par le gouvernement.
If I can begin, we really welcome all of the innovation we've seen around the world in both repurposing older drugs or drugs that are used for other indications and putting them into trials to see what impact they will have on COVID-19. We are also very grateful for all the investment and work going on for developing new molecules that may prove ultimately to be effective in the treatment. And we maintain a global database of all of those drugs and all of those trials. And we're encouraging all innovators to work through their national regulatory authorities, their national institutes of health, to ensure that any trials that are commenced with proper support and proper authority, proper ethical approval. And Africa has a strong track record in doing such work, and I'd like to congratulate the institutions in DR Congo especially, and Jean-Jacques Muyembe and his staff, because we have a monoclonal treatment which is highly successful for Ebola now, and that was developed in Congo with collaboration with NIH in the United States, but has been one of the first proven therapeutics against Ebola, a life-saving intervention developed in DR Congo and has been used successfully to treat in the last outbreak. Again, there is a tremendous amount of innovation going on in Africa in general. Maria mentioned South Africa, and again, it is interesting the way in which South Africa is bringing the disease under control, and how African countries are actually in some ways showing the way. The strategy in South Africa was based on preparation, primary prevention, lockdown and enhanced surveillance. 67 mobile lab units around the country, 28,000 community health workers trained in case detection, and I think over 120,000 tests completed with a 2.7% positivity rate, which is incredible, that much testing for that return. So we're seeing performance levels there again, congratulating the government and institutions of DR Congo for the superb way in which Ebola has been brought under control. We still have some way to go. So I think in general, we need to leverage the capacities that exist in Africa, the innovation, the science. We need to connect those scientists, we need to connect those laboratories, those clinicians across Africa. Again, the Director General, working with our Regional Director, Chidi Moeti, and the African Union have been heavily engaged in trying to drive innovation, both in the public and the private sector across Africa. And it will be very important that studies in Africa are led by principal investigators from African institutions, and obviously reaching out to collaborators in other parts of the world. And I trust that those capacities exist. And again, to point to the rapid evolution of capacity. At the beginning of this epidemic, and I will point to the fact that WHO began distributing validated testing kits in Africa on the 24th of January, which was 7 days, 8 days a week before the declaration of the global public health emergency. But it was the laboratories at Institut Pasteur in Senegal and NICD in South Africa that trained all of the laboratory technicians from all over Africa, who then met up with their new reagents when they returned home. We're also seeing the use of high-throughput diagnostic systems in places like Kenya, where superb technology that's been provided by the Global Fund and others has been repurposed to use for high-throughput diagnostics in many African countries. We're working very closely with the Global Fund, with UNICEF, with UNITAID, to accelerate the availability of reagents for those high-throughput systems. So I think we're seeing very, very good things happen, but we're very cognizant of the challenges. We've seen almost 250% increase in cases in Sudan in the last week, in Somalia nearly 300%, and in many other countries like Tanzania, Mali, Congo, Gabon, Equatorial Guinea, Capo Verde and Eritrea, increases of more than 100% in the last week. With many other countries in Africa, case increases somewhere between 30 and 90%. So We are at the beginning in Africa. I believe that with a focus on preparation, on surveillance, on community mobilization, and on the undoubted capacity for innovation and science in Africa, that we can avoid the worst of this pandemic. But we are also cognizant, as the DG said, that there are lives and there are livelihoods, and the impacts of long-term lockdowns are having a severe impact. So we have to find a way forward in Africa that can balance the risk of the virus against the risk to people's livelihoods and people's lives at the same time.
Thank you very much, Dr. Ryan. Now from DRC, we will go to Greece, where we have Costa from ERT. Can you hear us, Costa, please?
Yes, I can hear you. Can you hear me?
Yes, please go ahead.
Yes, thank you very much for taking my question. My question is about COVID-19 and sports. Can you please confirm that there was in the last days a teleconference between WHO and UEFA and the proposal to suspend the football championships until the end of 2020?
I can start, and perhaps Mike would like to. I'm not aware of the call, but it could have taken place, but I'm just not aware of it. What WHO does is we provide recommendations on how people can take decision about these types of sporting events and mass gathering events, for that matter, and what needs to be put into consideration, whether to hold it or whether not. The decisions are with them, and we support them in taking those decisions.
Now, we will follow up, as I'm not aware that there was any specific call, but we do all the time engage with organisers of major events, and we've been doing so with the International Olympic Council, with FIFA, with many others. So we've been engaged with religious organisations and so many more. And those engagements are frequent and are happening at different levels of our organisation. I think UEFA is the European institution, so we'll check with our European office. What's most important in this, in terms of sporting events and others, is sporting events, especially large sporting events, representing themselves mass gatherings. And bringing those types of events back online is going to require some very, very careful planning. Got a lot of sports fans here in WHO, and we miss our sport too. But we all want to be safe. And therefore, I think sporting organisations and governments, working both nationally and internationally, are really going to have to look at how do we adapt. And this is one of the things we've been discussing internally here, is on the one hand, we have the science and we have the evidence. On the other hand, we have the practical reality of life. Now, how do we adapt our evidential standards to what is the need to live and the need to manage risk at society level? If we all accept that there's no such thing as zero risk, the danger for governments at the moment, or the challenge they face, is that if they do something and there's any risk and then there's a consequence, they're going to be blamed for the consequence. No one will remember that they did that on the balance of risks. They'll only remember something bad happened. Therefore, when you bring a mass of people together and something goes wrong, people won't be shouting afterwards, oh, we were the ones that wanted that to happen. It won't be that. People will say, why did you let that happen? Why did you let so many people come together? And it's your fault now because you've let all these people come together and now we have another outbreak. So what we have to do is come to a new contract, a new social contract that allows governments and communities to engage, to co-manage the risks and say, okay, what risks are we prepared to accept, manage, reduce? So can we look at the real risks? Can we work together to reduce those risks to a minimum that's acceptable? Can we have in place a means then to manage something if it does happen? And then can we do that on a no-fault basis? Can we do that on the basis that we've all agreed that this is the best thing to do? Because you're never going to reach a point where there's absolute scientific evidence that it's safe to bring 10 people together, or 20, or 30, or 40, or 60, or 200, or 2,000, or 20,000, or 200,000. What we know is large numbers of people gathered together in close quarters in the presence of the virus will result in amplification of the disease. Best evidence would suggest that the physical distancing of people is very effective in reducing the risk of that spread. Where you then compress that distance to almost nothing, then you have to accept that the risk increases. Because if the basis of risk reduction is to physically distance people, then pushing people back into very close contact by extension says the risk will increase. But at the same time, people want to get back to normal life. So I think this is going to be, it needs to be a carefully discussed process. It will be driven by science, but it also has to have an element of practicality about it as well. I'm sorry to not be as precise as you may want me to be, but these are considerations that really have to be considered at a societal level, and it has to be based, yes, on evidence, but it also has to have a practical consideration as to how do you adapt science and evidence to the reality of living lives.
Thank you very much. We will now go to Argentina. We have Valeria from Radio CNN Argentina. Valeria, can you hear us?
Oh, hello. Are you listening to me?
Yes, please go ahead.
Hello. I would like to know what do you think about the evolution of the pandemic in South America? Thank you.
So thank you for the question around the evolution of the pandemic in South America. So what we are seeing is, I have to look at all of my numbers, is that there's increasing trends in terms of case numbers in a number of countries in Central and South America. And of course, this is a worry, because what we are seeing is that once the virus has an opportunity to take hold and to really transmit between people, if measures are not in place, then it can take off very, very quickly. And you can see doubling times of 3 to 4 days, which is incredibly rapid. And so what we need to see happen in South America, and what we are seeing that is happening in South America, is that all of these measures we've been talking about, so getting these laboratories to be able to identify cases, making sure that the surveillance systems are in place and the workforce is in place to be able to detect those cases. We've seen in a number of countries that public health measures and social measures have been put in place with some stay-at-home orders, and that is buying some time. But again, as I said earlier, it's important that we use that time wisely. There is very strong commitment by governments to have an all of society, all of population approach to engage populations, to bring them along, to be able to inform them and to seek input back. And that's really important. We're seeing the trajectory of this pandemic, the trajectory of this outbreak in every country depends on how each country reacts. And that is consistent across all countries, regardless of high income, low income countries. And so we are seeing an increasing trend in case numbers, but there still is opportunity. The window of opportunity, as Dr. Tedros has said, still remains in many countries to be able to suppress that transmission and to ensure that we don't have massive outbreaks in some countries.
Thank you very much, Dr. Van Kerkhove. Next question, we have Priti Patniak from the New Humanitarian. Priti, can you hear us?
Yes. Can you hear me?
Yes, please go ahead.
Yes, my question was for Dr. Tedros or Dr. Ryan. I wanted to find out, all the considerations that organizations like WHO and its partners take with respect to diverting funding or putting on hold activities that are meant for addressing other infectious diseases and having to take a call vis-a-vis their fight against COVID. What are some of the considerations, if you could speak about it briefly?
Hi, Priti. I think all countries face this same issue. A major emergency, number one, it diverts attention, it diverts time, and it can divert resources as well as you focus on what is most urgent and most dangerous. but the Director General may speak on this, but there are essential health services that are in place, core immunisation services, services to refugees and to displaced populations, TB, HIV services. As Maria says so many times, women are still giving birth all over the world and need safe antenatal and delivery services. So this is something that needs to be preserved, these core essential health services, and it's really important that countries try to do that. We have a whole team here and across the world that is dealing with sustaining essential health services, led by Ed Kelly and with regional counterparts, and we take that very seriously. The UN has been working very diligently over the last number of weeks under the leadership of Robert Piper in New York, looking at this across the system in sustaining essential services across all of society, with health services at the centre. And I believe there will be a major release of information and publication on that over the weekend or early next week. But we've been working very much with them on that. Certainly in our area of emergencies, you know, the conflict in Syria, the conflict in Iraq, the conflict in Yemen still exist. The fragilities in Somalia, in South Sudan, in the Sahel still exist. And our teams on the ground continue to work with governments on them. They haven't gone away. And they won't go away, unfortunately. And therefore, we continue to be focused on dealing with COVID-19 as well as doing the other things that we do. And we have major programs in all of these areas. The other concerns will be that we have a major yellow fever threat in parts of East Africa that must be managed. We obviously have always the threat of cholera and other epidemic-prone diseases. As you've seen, we've had the resurgence of Ebola in DR Congo. So we need to keep an eye, and we have one of the things we've done here in Geneva. We have a completely separated team who are doing nothing else but managing epidemic intelligence, verification and response for other epidemic-prone diseases and emergencies, and we've isolated that team to only work on that so that we don't miss things. And equally the same on the humanitarian front. And Dr. Ibrahima Sosé Fall, our Assistant Director General on the emergency response, is dedicating almost all of his time to leading on the humanitarian front and co-chairs the IASC Committee on COVID-19 and sustaining humanitarian response with Mark Lowcock. So we've done our best to try and preserve our services and our support to countries across all of these areas, but I have to admit that is not easy in the context of the resource constraints we face in continuing those programs.
Thank you very much, Dr. Ryan. Now we go to Jerry from Guyana Catholic Standard. Jerry, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, please go ahead.
Hi, good morning. My question is, there's a lot going on in my country especially, and around the world. People are not really aware and serious about this stuff because, as you know, religious gatherings are going on. And secondly, some protest against lockdown.
Well, a very good evening to you. I'm Chris.